I'm talking about the breast. I want to talk about facts, some of the fiction that is out there, and also reality. We're trying to make some sense of what's going on out there. Before I go any further, however, I want to give thanks to some people who are very, very important and crucial in this fight against cancer. And in that vein, I'm talking about the Cancer Society of the Bahamas. They're doing a tremendous job. They're not getting the praise and support that they should be getting. But I can say that 30 years ago, I was the recipient of the first mammogram machine in this country at Princess Margaret Hospital through the benevolence of the Cancer Society of the Bahamas. And at that point, 30 years ago, we started looking for breast cancer. And the Cancer Society has, without fail, been pushing and pushing and educating and reaching out to the country, not only in Nassau, but to all the islands in the country, about the importance of breast cancer and awareness of it. So I want to shout out to them and give them special thanks. And also for other groups like Sister Sister and the Bahamas Breast Cancer Initiative Foundation for the efforts that they're making to make us aware of this scourge called breast cancer. I've always started my talks with a simple question to kind of get a feel of where people are as far as their knowledge of breast cancer and what's happening in our country. I came home in 1980, the first trained certified Bahamian radiologist. And when I came home, I asked a certain question every time I went out giving a talk with the Cancer Society on cancer and so on. I asked a room like this, how many of us in this room know somebody right now today who is suffering with cervical cancer, cancer of the cervix? Could you show me with a show of hands? Anybody? Look around and see. There aren't any hands up. In 1980, when I asked that question, almost everybody in the room put their hand up. How many of you in here today know somebody that's got breast cancer? Look around. Now, everybody's going to say, oh my God, what's happening? Breast cancer. Well, I'm going to come along in a little bit and talk about why I asked that question and the relevance of that question and the answers that we just saw. So let's start first with the good news. The good news is that breast cancer is no longer a death sentence. Before we got that mammogram machine from the Cancer Society back in 1986, if you had breast cancer, chances are you were going to die. And everybody was afraid of breast cancer and so on. People were dying also all around us from cervical cancer. But I can stand here today with great confidence and tell you that it's no longer a death sentence. Now, my wife's a pathologist, and she's going to actually share with you tonight something. But she can tell you from the pathological standpoint, there's about 9 to 11 different types of breast cancer. So they'll say this one is an invasive ductal, or this one will say it's a lobular type of cancer. That's just a brand. But for you tonight, I want you to believe that there's only 2 types of cancer. There's the one that we can cure and the one that's going to kill you. The one that we can cure is the cancer that's caught early and small enough that it's still in your breast. It hasn't gone anywhere. It's all in the breast. The old people used to say, you can't close the door or the gate after the horse has gone through. Well, when the horse has gone through, we call that metastatic cancer. That's when the cancer is no longer confined to your breast. It is now spread to the rest of your body, and it continues to spread. That is no longer breast cancer. I want you to keep that in your mind. When it's spread, it's no longer breast cancer. It is body cancer, and that's why it kills. It's all over the body. And that's why you have to have all the chemotherapy and the radiation and the surgery and the this and the that, and it comes and it goes, but it will kill you. So remember, going forward, there's only two types of cancer. The one that can be cured and the one that's going to kill you. So, more good news. Everybody wants to know what's happening with breast cancer. And there's a lot of talk out there. Everybody's talking about breast cancer and who should have it and who didn't have it and who needed to have this type of treatment and that kind of treatment. The good news is that certain things have occurred over the last 20 years that has made breast cancer no longer something that's going to kill you if we follow the right path. We've seen a gradual reduction in the amount of women over 50 that have breast cancer. We've seen a distinct reduction in the mortality from breast cancer. So today, less women are dying from breast cancer. Whether all the hype out there. And remember, you know, there were articles that used to tell you, you mustn't eat margarine, you mustn't eat eggs because it's bad for you. Well, all of that is marketing, right? Somebody wants to sell more eggs, they pay somebody to do a research project that will come back and say eggs ain't bad for you, right? And that's what's been happening. We know the pharmaceutical companies, they sell chemotherapy agents. They're very, very expensive. If all of a sudden the word gets out that they don't need chemotherapy anymore, they're out of business. They're going to lose a lot of money. So it pays them to continue the hype that you're going to need this and you're going to need that and you're going to die and so much have that. So this is what I'm talking about when I say I'm trying to clear up the confusion about breast cancer so we can get down to what is real, what is tangible, what you need to know. Okay. So this is the question that everybody always asks. Why do you have so much more breast cancer today? Do we? A lot of people in here tonight are my friends, and we were all little kids together. We used to go to church, and Miss Thompson died. And somebody, what happened to Miss Thompson? She died. What happened? She was old. Right? Miss Thompson was 60. She was old, but she died. Right? We assumed that if she was 60 or 50 and over, you was old and you can dead, right? I mean, it's as simple as that. Nobody asked what killed her. She was just old and she died. What's happening today? Oh, Miss Thompson died. What happened? Oh, she had breast cancer. She was 75. She wasn't old no more. She had breast cancer. Right? Take that point. More women are finding their breast cancer earlier because we're talking about it. We're saying go out and get your breast examined. Go out and get your doctor to test you. And what happens? More women find their breast cancer earlier. They get treated and they are living. They're you know, you saw the race last weekend? I'm a breast cancer survivor. They're running around and they're proud. I'm a 5-year survivor. I'm a 9-year survivor. I'm an 18-year survivor. What does that mean? Well, Ms. Thompson, who was dying at 75 as an old woman, was alive at 75 telling you that she had breast cancer. But before, we, the young children, dared not ask what killed Ms. Thompson. She was just old. And if you asked out of turn, you were slapped down quickly and said, shut up, you're a child, you're not to ask those kinds of questions, right? But Ms. Thompson had breast cancer. But most people didn't know about it. Today, when Ms. Thompson, who is 75, gets breast cancer today, everybody knows about it. Because if she doesn't talk about it, her children talks about it, and so on and so forth. So, more people are speaking about breast cancer. More people are surviving breast cancer. So it seems like everybody has breast cancer. But I don't think the actual number of patients with breast cancer have gone up that much. They may have, but I don't think the absolute numbers have increased so dramatically. It's just that more of us are talking about it. I started out just a while ago and I said, how many people know somebody with cervical cancer? How many hands went up? None. But when I came here, cervical cancer was the rage. It was killing women left, right, and center. And almost the room knew somebody who had bad cervical cancer. You know what happened? The pap smear came along. And any woman who was sexually active or past a certain age was given a pap smear every time they went for their checkup. And what is the pap smear? The pap smear is the mammogram for the cervix. It finds the cancer before it became a lump on your cervix, before it became a big killing cancer that has already spread. So what happened? The more women got pap smears, the more quickly and more distinctively they were found to be either having changes in the cells of their cervix, which suggested that they might eventually develop a cervical cancer, or they had early changes of cervical cancer, not yet a lump. And the surgeon went in, or the gynecologist went in with those reports from the lab on their pap smears and just did a little cut of the lining of the cervix down to the muscle layer. And these women were cured. That's why we don't hear of women dying from cervical cancer today, because they're getting treated before the cervical cancer becomes a killing cancer. So, ain't nobody dying from it no more, ain't nobody talking about it anymore, right? So, that's why it seems now that mammography and breast cancer is the talk. It seems like there's so much more. No, it's so many more people are actually talking about breast cancer. Haven't lost anybody yet. Now, all breasts are not the same. People talk about, well, which mammogram machine is the best one, and which doctor is the best one, and so on and so forth. I, by training, when I came home in 1980, I am a brain and spinal cord diagnostician. I dealt with the brain and the spinal cord. The breast is the scariest organ structure in the body from the standpoint of my job, which is a diagnostician. Because, see, this is chest. Everybody knows that those are chest x-rays, right? That's a chest x-ray. Everybody knows that's a chest x-ray. But you see the one on this side? That's normal, right? This doesn't look like that one. But we know that's a chest x-ray. So immediately we know something's wrong, right? Anybody, all of you can see that. Well, all breasts aren't the same. And keep forgetting I'm pushing my, which is not that one. See those? Different. This is what some breasts look like. This is what some breasts look like. You do, no problem. Because why? See that? That's a cancer, and that's a cancer. Take that white bit of rice and put it in this plate of white rice and tell me you can see it easily. You can't, can you? And this one's not so bad, but all breasts are not. This is another set of breasts, very, very dear and close to me, but there's a cancer on two of those pictures. I won't show it to you now, but that's another type of breast from that and that, right? It looks a little bit different. So does those. That one over there is the one, that's the one I want to see, because look at that, a huge cancer, right? But there's a cancer in this one too. There's a bigger cancer in this one right here. And I can't see because the light's in my eye, but there's supposed to be some little white dots that you see here. These are called calcifications. If we could get them onto the film, thing to make the film, and don't break your wrist, this is what I love to see. Why? Because as I showed you before, the cancer on these are so easy to see. You can park a Volkswagen in here and see it, right? Because the cancer is white against a black background. But they're not all like that. Some look like that. This is a plate of white rice and one of the grains is bad. As a diagnostician, pick out that cancer in there. That's why we have you go for an ultrasound, or you have to have an MRI. Because there's no way anywhere in the world with the best machine in the world, with the best diagnostician like myself in the world, can we pick out abnormal white grain of rice in there. 10 to 15 out of 100 women have breasts that look like this. This is a so-called dense breast that they talk about. Mammogram is almost useless. And then we have strange but true. We have polythelia and polymastia. Polythelia means we have a bunch of nipples. We've all seen dogs and cats that are pregnant. We see the nipples coming right down from the shoulder down to the pelvis. Well, we are no different. We have the same thing. So we can have all kinds of nipples. So in this, you see there's a nipple here, there's another nipple here. Some women have an extra nipple on top of her breast, right? So this is polythelia. Back in the 1900s, London, a woman nursing a baby on her chest and a toddler taking breast milk from her hip. Interesting. But just to tell you, all breasts aren't the same. All right, take a deep breath. And we're going to move on. A woman needs to be aware of her breasts like she's aware of her face. My wife of 47 years, right? Yeah. My wife of 47 years can tell when I'm having a pimple. She said, boy, you got a pimple coming out there. And I said, where? And she points at it, and then I could feel, when she presses, I could feel a little discomfort. She can see it long before I can see it. And they've got my back mapped, and all my kids, my girls, they come and they say, Dad, I'm going to squeeze all of these things. So they know. They know my back. They know exactly which one looks like it's ready to be squeezed and stuff like that. I stress that because if women can know their faces long before the pimple is visible, that something's coming and they start to put the cream on and all this kind of stuff, or they can know my face and know that there's something happening, then who is to say that you can't know your breast the same way? And in this business, like the Bible says, a 3-stranded cord is better than one, right? And the 3 strands in breast cancer diagnosis is you, the owner of the breast, your clinician, your physician who examines you, does the physical exam, and then me, the diagnostician, who will do your mammograms and your ultrasounds and your biopsies and stuff like that, and tell you what I think is wrong. But nobody knows your breast better than you do. It makes no sense you coming into my office and saying, I want you to examine my breast. And then I go, and the first thing I feel is a marble in your breast, and I said, how long that been there? I know. You ever felt that? I ain't think so. When was the last time you examined your breast? I know. So the reason that is important is that there's certain things that can occur in your breast overnight. Usually in perimenopausal women, you can form cysts the size of a hen's egg. That wasn't there today, and in the morning when you wake up, there's this egg in your breast. I've had women freak out over that. I had a lady run off the ship, one of the cruise ships, and come to the hospital, to the emergency room, because this large thing showed up in her breast. And I went in and I said, when did you first notice this? She said, well, it's only this morning. I said, you sure? When was it not there? When was the last time you examined your breast? I felt my breast yesterday and it wasn't there. I said, so go and sin no more, you're good. Because I knew it was a cyst. I put a little needle in it, sucked out the fluid, and she went. All right? There are women walking around that have 15, 20, 30 of these in their breasts, both sides. And one particular friend of mine I've been following now for about 15 years, she comes occasionally and she says, one got a little big, it hurts, can you pull the fluid out? And we pull the fluid out and she's good to go. Nothing to worry about. But if you don't know that, you're going to freak out, right? And that's where you have to be able to come to me and say, this only came up since yesterday, it wasn't there yesterday, or it wasn't there last month. Then I can say, well, cancer doesn't grow to this size in a month. Don't worry about it. It can't be anything bad. But just for clarity, this is her breast in 2010. This is the same breast in August. And there's a little doohickey here. But is it different to that? Well, yeah. But it doesn't look like a cancer. And what had actually happened is that she had this in the film we took in January. That's changed significantly. It looks like two things now. But even those two things by themselves don't look like the cancer I showed you earlier. But that's why she's the pathologist. The final arbiter as to what it is the woman or man who looks through the microscopes and looks at the cells and says, these are malignant cells. So even though I can say this looks like a cancer, we still have to biopsy it and get confirmatory affirmation from the pathologist. So we took this out. This was 10 millimeters. This had gone to 13 millimeters, 3 millimeters more. This wasn't even the size of a dime. All right? Now, I want to explain what happened and why in August, when her doctor examined her breast, she couldn't feel it. And she herself, examining her breast in August, couldn't feel it. Without getting too technical, the pathology of cancer is such. She had not only a cancer in here, she had two benign lesions. She had a fibroadenoma and a papilloma, and she had an in situ cancer. You hear them talking about ductal cancer in situ or DCIS. She had LCIS, lobular cancer in situ. And then she had an invasive lobular cancer. That's a small, those were both small. And then next to that was a papilloma, which is a benign tumor, and a fibroadenoma, which is another benign tumor. She's been a lump fact-free from the time I met her. In medical school, she had her first fibroadenoma taken out. She's been making lumps. So I've been watching lumps in her breast, but not in this left breast. I was watching the right breast, because for the last 5 years, there's been a lump there that I've been watching. Probably that's why I didn't pick up on this one so much, because the one in her right breast we've been watching for years hadn't changed. But what happens is when the lobular carcinoma in situ, which is like the cervical cancer that the pap smear is going to pick up, where the cancer is only in the cells. There's no lump. It's only in the cells. But when it breaks out and starts to spread, it invokes what we call an inflammatory response. Many people have seen an ankle sprain. At the time of the ankle sprain, the person gets up and they can't walk on their ankle. But if you looked at it, it's not swollen. It just, you know he must have sprained his ankle. The following morning, unfortunately, that ankle is about this big. That's what happens when the invasive cancer occurs from the in situ or the cellular cancer. When the cellular cancer grows and becomes invasive, it invokes this inflammation, this swelling. And that's why when all of a sudden she could feel something there, this thing got swollen by 3 more millimeters. And she can feel it. That's what I mean by knowing your breast. Because if you were feeling your breast all the time, you could have felt something there, but all of a sudden you notice that it's harder, as she said. It was more firm, it's more distinct. It wasn't the same as it was before. So that same morning, when I did the mammogram, I did an ultrasound, and the ultrasound confirmed that something was going on. So I lined her up for surgery the next morning, and we couldn't really feel it that well, but I could, once I put the ultrasound on it, we can narrow it down. The surgeon goes in, and he takes, not the silver part, he takes all out here, where my fingers are, he takes a big piece around it, so that the cancer stays complete, and we have normal tissue around it. That's why I'm telling you, if you can get a breast cancer early, confined to your breast, not yet spread, you can cut it out and you're fine. So we say praise the Lord, and we move on a little bit now. So these are the changes that you need to know. A lump, and my wife's case, a firm area in your breast that is new or changed. If your breast size changes or its shape changes, all of a sudden you notice it looks like it's got a little dimple in it, or it's pulling, or it is not shaped like nice and smooth anymore. You need to do something about that. You need to go tell your doctor. If you have itching and redness around the nipple, there's a disease called Paget's disease of the breast. That is a type of cancer because the cancer is coming down the milk ducts, coming out the milk ducts, and then it's irritating your areola. And you get something looking like an eczema, but that's a cancer. Dimpling, when areas of your breast start to take on the appearance of an orange, you know the little holes you can see and you can see, we call that a French term called peau d'orange. It's the appearance of an orange. If you get that, unfortunately, that's advanced cancer. You've had it too long and you haven't been noticing it, and when you do notice it, everybody else can notice it. But that's a sign of cancer. And then a discharge from your nipple. You can get all kinds of discharges from your nipple because you got those ducts. When you stop making babies, you can have blood. You can have something cheesy green or brownish come out of your nipple. That's just the backed up stuff that normally comes out of your nipple. And if they get blocked, you've got 15 to 20 openings in your nipple where the milk comes out. Anybody who is breastfed will know. You'll see they go in all directions, these tiny little spurts. Well, those ducts can get blocked just by the skin flaking off on the outside and on your nipple, or you put too much powder and you block it. Then when they block, the stuff that normally comes out secretes very slowly and is absorbed into your bra that you don't normally see will now start to back up. And then one day you kind of just push on your breast hard and all comes this nasty looking green stuff or cheesy yellowy stuff. Not to worry about that, that's normal. But if you got blood, or if your breast starts to exude something looking like just plain old-fashioned saliva, then you have a problem. You need to get that checked out. Because blood can be a benign, nothing to worry about item called the papilloma, which my wife had in her breast. We all know when we used to be able to run outside in the yard, and the kids today wouldn't know that. But if you caught a wasp nest when it was just beginning, you saw this tiny little thing hanging from the leaf or from the top of the rafter or wherever the nest was going to be built. Well, if you can imagine something like that hanging on the inside of the milk duct, that is what a papilloma is. It's a growth that is coming from the lining of the duct. But every time you rub now, that's on the inside. And as that rubs on the inside of the duct, it bleeds. And the blood eventually works its way out through the nipple, and then all of a sudden you come to me and you say, I found a spot of blood in my bra. And then we'd squeeze your nipple and a lot more blood would come out. And we'll say, all right, we got to examine that to see what it is. And then we can do ultrasound or certain tests, and we can say, yeah, you have a papilloma. Or if it really looks bad, this is a big papilloma, or it looks like a funny papilloma, we got to biopsy that or have it removed. Because that papilloma may in fact be a papillary cancer. Okay? Anyway, not to scare you, let's go on. So there's my friend again. So this thing about screening. First off, we don't have breast cancer screening in the Bahamas. Much to a lot of people's chagrin, we cannot say that we have breast cancer screening because the concept of screening is such that the government is supposed to send out a notice to women within a certain age range that you're invited, so to speak, to come and have your normal breasts checked. You know you buy a new car, and when you drive out of the car, the last thing the salesman says is, at 1,000 miles, I want you to bring it in for your first check. And then they give you a maintenance schedule at 5,000 miles, 6,000 miles, 9,000 miles, so on. You bring the car in and you have it checked. There ain't nothing wrong with your car, right? But they know that things can go wrong. And so they bring the car in while it's still under the warranty, so they can check it. If this is loose and it might fall off if we don't tighten it up, we tighten it up. if this is rattling, we can stop the rattle. Or they'll come back and say, everything is fine, we just changed the oil, and there's nothing wrong with you. That's the concept of screening. We want to be able to tell you that we've looked at your breasts, and yes, you feel that nothing's wrong with your breasts. We agree with you, your breasts are normal. Go and sin no more, like the Roman Catholics would tell you, right? And that's what screening is all about. Everybody of a certain age in the country is invited to participate. It's not if you could afford to have a mammogram or when you feel like it. Because the way that works is that if everybody this year who has the need for a mammogram goes and gets their mammogram based on their invitation to have it screened, then the results of all these tests get back to the government, and they now have an idea of how many women got mammograms this year, how many women had abnormal mammograms, how many women had normal mammograms, so that when we add up all the figures, how many women had cancer, how many women didn't have cancer, how many lumps were benign, how many lumps were malignant, we have a clear and concise and accurate measurement of what's happening in the country. Nobody in this country today can tell you the incidence of cancer in this country because we don't have a registry that is functioning yet. But besides the registry is the little area that they keep all this data, that she had a breast cancer, it was taken out on such and such a date, it was benign, it was that type of cancer. So all this information goes into a central repository, and with that central repository we're able to extract all the information that we can give to the country, give to the women and say, because we have this high amount of cancer, we need to take these steps to try to do something about it. But we, the people, besides the lack of the registry, we're not loyal to our country. Because some of us go to Jamaica, some of us go to Cuba, some go to Canada, some go to Palm Beach, some go to Miami. And we never hear about these people and what they were found to have. But they come back and they live in our society. So we still don't know how many women we have with cancer because half of them have gone to elsewhere general in other countries, had their treatment and come back and nobody knows the truth. So when do you get your mammogram? When do you get it checked? Screening means in the United States, which is all we can go on because that's the only figures that we have close by that are semi-reliable. They say you start your first mammogram at age 40. Sorry. At age 40, you can get a what we call a pre-screening mammogram at age 35, so-called baseline mammogram, just to make sure that everything is normal. That's like what the insurance company does when you buy a car now. They say, come, let us see this car before we give you insurance because it might have a dent here or a bump there. And if it's good, then we'll give you the insurance, but if it's got this bump, we're going to have to change the rates. Well, if you go at 35 and everything is normal, you can wait until you're 40 and then go into the cycle. Every year until after menopause, you should have a mammogram. And why is that? Some people talk about having a mammogram every other year. Well, it used to be if you're under 55, you have a mammogram every other year. That was before the research showed that that makes no sense because it's the pre-menopausal women whose cancer can double in size in 6 months to 18 months. So if you waited 2 years to get your follow-up mammogram, by the time you came back, the cancer that we were going to pick up that had just started to grow would have doubled in size and started to double again. So they reversed it and said, between age 40 and menopause, you should get a mammogram every year. Now, after menopause, they say you should still get a mammogram every year if you have dense breasts. All breasts don't look the same. The ones that are difficult to diagnose, you have a family history, you have risk factors, you should continue to go as long as you want. But if you have no symptoms, you got gazongas with only fat, you can go every other year because after 55 after menopause, a breast cancer can take up to 10 years to double in size. So it's not going to sneak up on you in 6 months and kill you. It could if you're premenopausal. Okay? Have I confused everybody up to this point? I see some funny looking faces. Anyway, then the other thing that we've found recently is that this high-risk breast cancer, the genetic breast cancer, the family cancer that we know we have, because you can talk to families who you know the mother had it, her sister had it, her auntie had it, the daughters, all the daughters have it, and even the sons had it, right? That is genetic breast cancer. That is the one where we've had this mutation in the BRCA1 and BRCA2, breast cancer gene 1 and breast cancer gene 2, right? Those genes have undergone a mutation in these people, and 80% of them will develop a cancer of some type, either ovarian or breast. Now, it used to be taught up until about a year and a half ago that the highest penetrance, the group of people or the race of people with the highest amount of genetic cancer were the Ashkenazi Jews. And we talk about penetrance of this gene, and they had a penetrance totaling about 12%. So 12% of all Ashkenazi Jews were positive for this gene mutation, which gave them all an 80% chance of developing this cancer. And they always talked about, thank God you're not an Ashkenazi because they have such a high incidence of genetic cancers. Well, about 2 years ago, we undertook a research project that I knew the answer to since I started 30 years ago looking at Bahamian women and breast cancer. And with the help of a lady, Susan Hurley in University of Miami, they did this research on known breast cancer cases from the Bahamas. They examined 200 women who had breast cancer, and they found 1 in 5 of those women were positive for the BRCA1 and BRCA2 gene. You know what that means? That no longer are the Ashkenazi Jews the leaders of the breast cancer gene penetrance. We are at 23.5%. So, what does that mean? Mr. Roll probably had a bicycle, and he spread it around because, see, the Ashkenazis know that they're Ashkenazi. If you are Johnson, you have this gene. But in the Bahamas, we always thought we all mix up like conch salad, right? Mr. Roll did have a bicycle. So Mr. Roll had the gene, but he was with Miss Smith. Miss Smith now has the gene. So we can't say if you use a Roll, you can have the gene, but if you use a Smith, you don't, because Miss Smith got some Roll in it, right? You see what I'm saying? And this is where we're in a mess. We're in a total mess because we cannot narrow down the group or the families except to say if you're Bahamian, 1 in 5 of us who will develop a breast cancer are going to be genetic cancers. But they're the lucky ones, believe it or not. It's like people I diagnose them end-stage cancers. You're going to die. This is too late. You're the lucky one. You haven't died yet. You have time to make your peace with God. You can say your this and you can do that and you can put all your stuff in order. The women who haven't had their kids yet will hurry along, get their kids done, out of the way, and then you can go and choose to have your breast taken off. You can have your ovaries taken out, and you can do something to prevent yourself being one of those 80% that will develop the cancer, right? The other 4, unfortunately, are the ones that I worry about because they're environmental cancers. They're the ones that there's no known cause that just popped into your breast. Now, I caution the guys with that research not to stress the breast cancer findings so much, because why? This whole room is, well, I ain't got nobody in my family that no breast cancer, so I don't have to worry, right? Out of sight, out of mind. So you think you don't have a genetic cancer, therefore I don't have to worry. But it wasn't 4 genetic cancers versus 1 environmental. 4 of the 5 had environmental cancers. Those are the women that still have to be checked. They have to make a special effort. That is why diligence on your part is important. You can't assume, I don't have no family history, I'm not going to get it. You don't have any forewarnings. At least if you know you got the positive gene, you can look out for it and you can expect it. If you don't forget that it can still come and get you. All right? So let's move on. The youngest woman I've found with a breast cancer in my practice has been a 21-year-old with a 3-month-old baby. And she came in at a stage 3. That means she had a tangerine in her breast. That's the size it was, and it already spread. She was obviously a BRCA positive. Here's where it comes back to that question about which age do you start. The North Americans and the Europeans are touting, and if you look, just recently, like I think this week or last week, there was an article in the paper about when do you stop having breast mammograms, how old is too old to have a mammogram. Well, the British have said for years they will not screen a woman's breast. That means they ain't paying for your mammogram unless you're over 50. And if you're over 50, you can get your mammogram, but only once every 3 years, I think it is. Right? They will pay for it once every 3 years because they think that's the incidence at which breast cancer screening should be done. Now, this girl at 21, she would have been dead 3, 4, 5, 6 times before she got eligible to have a free mammogram. Most of the women in the Cancer Society that I used to work with when I started looking for breast cancer were under the age of 40. And they all were diagnosed somewhere around 35, 30, 28. They were breast cancer survivors before they were 40. One girl that worked for us at Doctor's Hospital, she got breast cancer in both breasts that spread to her brain before she was 42 and died. That's the BRCA gene. That's the breast cancer genetic gene. So we cannot afford to have our women wait until they're 50 to start getting screened for breast cancer. Because that number does not hold for our community. And that's why we had a fight. I had the distinction on World Cancer Day last year to speak at the World Health Organization and Pan American Health Organization conference in Washington on breast cancer in the Caribbean and screening and blah, blah, blah. And there was a panel of 4 people, myself, one lady from Brazil, one lady from Mexico, and a gentleman who was a North American cancer surgeon. And he was a head of some task force and so on. And he kept insisting that mammograms and screening was not effective or worthwhile before age 50. And I had to get up and defend what I knew from my experience, and I had to tell him, I'm sorry, that data that you're quoting cannot work in my country. And then the Mexican lady got up and she says, that is true. And then the Brazilian lady got up and says, well, you know, if you white North Americans and Scandinavians and Europeans, this is what is good for them. You cannot drop that data on the rest of the world and make it stick. You can't say the rest of the world, therefore, is like that. And this is where you read in your books, your Cosmo and your Red Book and whatever, that this is the age to get it or you shouldn't get it because it's not effective. We can't take that data because we don't live where these papers or these books are being published. We can only know what happens here in the Bahamas. And a 21-year-old with a stage 3 gonna kill you in a year's type cancer is what I know for a fact. The youngest on record is supposed to have been a 14-year-old. Okay? I don't want these to scare you. I just want you to understand that there's a lot of confusion out there. A lot of people, as they say, a lot of noise in the market, but it's really not fact. Okay? It has to be specific. It has to be what is here, what we know to be facts here. Okay? So let's move on. So what does cancer really look like? This is a cancer. 73-year-old lady. That is about the size of a nickel. Okay? Now, it's close, what we call close to the chest wall. Makes it dangerous because the closer you get to the chest wall, the closer you are to the fence, the easier you can slip out, right? But chances are, she can have this removed, and what we will do is we'll not cut here, we'll cut out here. So we take any little bits that might be growing off the edge of this, and that's taken out. And as long as my wife, as she said, we have clean margins or clear margins, meaning when the pathologist looks at this specimen under the microscope, the tissue out here shows no evidence of cancer to the edge where they cut. If there's no cancer out to the edge where they cut, that means they've gotten the entire lump out. Okay? And then they do some other things. My wife from Trinidad, she says, the more simi-dimi, which means that they do some tests and they do some this and that. And they check for receptor types. Is it estrogen positive? Is it progesterone positive? These things all tell us what type of aggression this cancer has, whether it would be one that needs to be heavily treated or whether you can just put her, like my wife, put her on tamoxifen, which is a hormone, and she'll be good to go. So this is a small cancer that possibly can be cured. When I say cured, meaning if it's taken out, it's clear and it hasn't spread, she doesn't have to worry about it anymore. Doesn't say she can't develop a second cancer. Okay? I have one lady who came to me 2 years after being normal, and I found 24 separate cancers in her breast. It just exploded. Okay? So there it is. And you see this thing here? That is a marker that we put on your skin when you have your mammogram, because she said she could feel something right there. And that helps me, not so much in this one. This case is easy. It just looking at you, say, here I am. But you remember that white one I showed you? I wouldn't have been able to see it. But if I saw this, I know concentrated in that area, that's where the lump's supposed to be felt. So I look for other little changes that will help me make the diagnosis. This lady, this is a big cancer. This one's about the size of a quarter or just a little bit bigger than that. But again, it's confined to her breast. The breasts are fairly large, and hopefully, if she has no spread to her lymph nodes, this can be cut out, and she too can survive. And more than likely, she'll be, just with this alone, without anything else, even if she had early spread, she'll be alive in 5 years. That's how good our treatments become over the years. That's why a lot more women are surviving breast cancer and not dying from it. But then we got this puppy, the metastatic cancer. This is where the horse has gone out. Okay? It is no longer breast cancer because it's breast, and in this case, it's up in the neck, and we don't say the rest of the body. It could be anywhere else. This month alone, I've seen, since I came back to work, I've seen 4 cancers. One of the ladies that I diagnosed is already dead. The other one is going to die soon. And these other 2 that I just showed you, they're probably going to be okay. This is the lady, this cancer will kill soon. I don't know if you're good enough, but you see this is a breast? See how nice and smooth? Look at this one. See these lumps and bumps? Okay, if you can't see it there, here it is. That's a computer reconstruction of a CT scan. This is all breast cancer, growing out of her breast, up underneath her arm. These women don't need CT scans, they don't need mammograms, they don't need ultrasounds, because she walks in the room, I could smell her cancer, I could see her cancer from across the room. And all I could do is, you're gonna die. This is far too late. There's no way in God's name that we should be seeing cancers like this in this country today. But there's this little thing called denial, where a woman will know that she's got a piece of concrete in the breast that's been growing, and she hides it from her family, she hides it from herself, and she does nothing. And then they come in like this. And I don't know whether they come in for us to tell them they're going to die, or they come in thinking that we can cure them. Most of the time they come in, they know they're going to die. The lady that came in with another one similar to this, hers was over here. You can see a little bump coming out of her chest, kind of like this. This is a port where they put the chemotherapy in. But this lady had a bump like that coming out of her breast. And when I biopsied it, I know she wasn't going to last, because when I felt her breast, it wasn't like a breast. It was like it was harder than it was actually harder than a breadfruit or a cantaloupe. Sometimes they feel like concrete, like rocks, and that's cancer everywhere, okay? So this woman is going to die. No questions asked. She will die from this, and soon. Okay, I talked about this before. Cancer-free family does not necessarily mean you don't have to worry, okay? We have the genetics. You pass it down in your family, and eventually it gets to you. And then we have the environmental stuff. These are, people ask, what's the cause of breast cancer? Nobody really knows. And anybody that tells you that they know, lies. There's all kinds of talk out there, well, this can kill you, this is the cause, that is the cause, don't eat this, don't eat that. Well, before I go on to that, men also get breast cancer. It goes anywhere, the facts or the numbers or the data says anywhere from 1 in 400 breast cancers, 1 man to 400 women, or in this case, 1 man to every 1,000 women that has breast cancer, a man is going to develop a cancer. A good friend of mine came into me the other day, and this is one of my weaknesses. I so didn't want this to be a cancer. I tried to convince myself that it wasn't. That's dangerous for me in my job. That's why people don't understand. I don't look at names. I try not to look at names because it affects the way I make a decision, right? Because I still don't want you to have a cancer. I'll try my best to make it not. But in fact, any man with a lump in his breast has breast cancer until I tell you it's not breast cancer. That's the take-home message. Don't say it could be or it might be. Let us tell you it is not after we've done all the tests, after we've biopsied it. If a man has a lump in his breast, even if you saw the wasp sting him yesterday, still bring him to me and show me that lump, and let me tell you, yeah, the wasp stung him and it's getting smaller. But until I tell you he is free and clear, that is a breast cancer until we prove it not to be, okay? That's where you save your family members who are men. Cells change. Things can damage your cells, specifically the DNA in your cells. If you damage DNA, a cell with damaged DNA will undergo what we call a mutation. The BRCA1 and BRCA2 genes, the genes are part of your DNA. That is a mutated gene, DNA. It is, something's wrong with the DNA. And that mutation will predispose you to having cancer, because the deranged cell that comes from the damaged DNA, or the mutated cell that comes from the damaged DNA, does not develop into normal skin anymore or normal fingernails anymore. It develops abnormally and divides abnormally as a cancer. Okay? And that's why you hear them in the reports. The pathology report says an undifferentiated cancer or well-differentiated cancer. It means that the mutation was not so bad, so we can see when we look at the tissue, we can see that this is pancreatic tissue or breast tissue or lung tissue, but it's cancerous. But we know the cells still have a semblance of what their original purpose was to be, normal lung, normal pancreas, etc. An undifferentiated cancer, you just see an ugly, deformed, growing mass of cells that are abnormal. You don't know from what type of tissue this deformed cell came. So you can't call it a pancreatic cell or so on until you can see something that resembles pancreatic tissue. It's just an undifferentiated cancer. So this is the process. But none of these cause breast cancer. Coffee doesn't, soda doesn't, deodorant doesn't, microwaves don't, cell phones don't, and staying next to somebody with cancer doesn't. Okay? But we have risk factors that are important. If you're a sedentary lifestyle, you drink a lot of alcohol, those two, and you're on HRT. Now, radiation, on the other hand, whoops, my bad. Radiation, on the other hand, is known to cause damage to cells. We talk about the people who were survivors of Hiroshima and Nagasaki, where they exploded the first 2 atom bombs. They have all of those survivors have cancers and deformities and so on and so forth, simply because of the radiation exposure that they had. They then pass it on, the damaged cells in their eggs, for instance. Women, they have eggs in their ovaries. Men have sperm in their testicles. They were damaged at the time they were exposed to the radiation. And what does that mean? Then their damaged ovaries have damaged egg cells, and they have damaged sperm. And you put them together and you get a damaged embryo. So the child is born already with deranged DNA. And they're set up now to have a cancer. Okay? So those are the things that we know. Hormone replacement therapy. I talked about estrogen receptors and things like that. It is known that certain cancers postmenopausally or premenopausally will be fed. It's like pouring gasoline or kerosene on a fire. If you still have this hormone raging, in other words, you're premenopausal, and estrogen is still going through your body, cancers that are estrogen hormone receptor positive is like putting fertilizer on your plants. It will just grow because of the hormones. So they said when putting women on menopausal HRT, hormone replacement therapy to deal with hot flashes and so on, we were in fact fueling a whole new crop of breast cancers. So that's why they tell you now, if you don't have to, don't do it. And finally, it's a global problem. Everywhere in the world, this is a problem. 1 in 8 women in the world will develop a cancer. These are the things I talked about earlier about, this is the US facts. How many women get it, how many women don't. And finally, these risk factors can't be changed. Your age, your race, your family history, those can't be changed. So if you have a positive family history, you need to be checked for the gene. If you don't, then so be it. If you have a late menopause or an early menstruation, those are also supposedly linked as risk factors. And basically, these are other things that you need to be aware of. These are not cancers, these are benign. I talked to you about the breast cyst. Here it is, a bunch of fluid. Our fibroadenoma, that's a solid tumor, but it's not malignant. 46% of 46% of women have one of those, okay? And then this thing that's growing in the duct, the milk duct, that's the papilloma. Okay, it's like a plug in the pipe. Those will scare you. They will make you think you have a cancer, but these are benign. And finally, take a big breath. I'm done. Thank you.
You've been watching Doctors Hospital Distinguished Lecture Series, presented every third Thursday in the month. Thank you for joining us.